Okay, so hello everyone, and thank you for joining us today. I'm John Collins, working with the Parkinson's Society, where we've developed a program that we call Get It On Time, which allowed us to start a relationship with the Registered Nurses Association, of Ontario, and we've been providing these sessions for a number of months now, and I believe today it's our final scheduled presentation anyhow, so I do thank you for taking the time to join us. And
Mark Bruder
has joined the conference.
Hi, Mark. Thank you for joining us. I'll ask that you, if you're able, to press *6, which I believe mutes your line moving forward. And for all others, I will ask that you bear with me while I resolve a strange issue that just happened with our meeting layout. There we are, pardon me. At any rate, I am John Collins with the Parkinson's Society, and I'm happy to be here today just to have a chance to introduce this session. Wanted to make a few housekeeping announcements before we begin, just really largely that we will have a few polls that pop up throughout the session, and I see a few people have already voted in the Connection to Parkinson's poll, just a way to give us some feedback as we go. As well, if you have any questions, you're able to enter those in the questions and comments chat box on the right-hand side of the screen. Any other further questions that may come up that aren't appropriate to address in the chat box or you think of after the fact can be addressed through myself or through Heather Woodback with the RNAO, and our email addresses are here. We should note that the session is being recorded as well, so if there are those comments that you wish not to share publicly in an archive session, then do please send us an email. Otherwise, at this point, I'm going to ask Heather to go ahead and introduce the session for us.
Thanks, John. This is great. I can't believe it's our final session, but I think it's going to be a good one. We're really happy to have Melissa Northwood with us. And I'm going to ask Melissa to say a few words about herself in a couple minutes. Melissa's got a background in continence care, and this is such an important topic for people with Parkinson's that it's a good chance to learn more about it. So our objectives for today are to share best practices for resident-centered care for people with Parkinson's, discuss the impact of Parkinson's on the bowel and bladder, and
Heather, if I may, sorry, briefly interject. I see a note from Tina who's having some trouble hearing yourself, and I actually am as well, not through my telephone, but through my meeting room. So could perhaps ask if you're on a headset, maybe try an alternative for the moment, or just speaking a little louder into the mic. Sorry about that.
Okay, is this better?
Much better for me, I believe. Yes.
Okay.
Thank you.
Okay, thanks. It's good to get the technical stuff sorted out. Anyway, after we share best practices, we want to discuss the impact of Parkinson's disease on the bowel and bladder and look at solutions for some of the problems that arise due to the Parkinson's disease, and then describe some strategies for managing the symptoms. On the next slide, please. There's a few best practices that relate directly to this topic, and the first one is from the Registered Nurses Association, is resident or client-centered care, and it has these principles in it that we want to respect the patients we care for, promote human dignity, recognize that clients are experts in their own lives, see our clients as leaders in their care, and incorporate clients' goals in coordinating care that the healthcare team decides or suggests should be done. And then looking at continuity and consistency of the care that is offered, and as well, whenever possible, with the caregiver, the person who's doing the care. Trying to provide timely care, which is, we're going to hear, I think, again today how important this is, due to the effects of the medications that people with Parkinson's have to take. and looking at responsive behavior and giving people universal access. So on the next slide, prevention of constipation. I'm not going to go through all the recommendations, but mind you, when I looked at Melissa's slides, I thought, wow, most of these recommendations in the prevention of constipation best practice apply in this setting. Looking at the history, specifically looking at medical surgical history that's related to constipation, and neurological condition is in there. Number 3 is reviewing clients' medications. And so the Parkinson's medications would be one of those, and trying to get the fluid intake up and encouraging sips of fluid, and then looking at fiber, promoting regular, consistent toileting. And I'm not going to say much more because I'll start to steal Melissa's thunder. So on the next slide, I talk a little bit about the promotion of prompted voiding best practice. And you can see there's some real overlap, because we know that continence and constipation are very closely related. And in this best practice, they specify Parkinson's, looking at the relevant medical history and including Parkinson's disease. And, the medications are the same, looking at cognitive ability, looking for urinary tract infections. And then number 8, I love, is that we got to ensure that constipation and fecal impaction are addressed in order to promote prompted voiding. And then the fluids come up again. I just want to draw to your attention that there's the Best Practice Toolkit, which is an excellent resource. The section on continence and constipation has a lot of different resources around this topic that people can use. There's assessment forms. There's other best practices. There's some nice like educational resources for staff on there. Now I'll just mention a little bit. The Canadian Parkinson's Society has their own best practices on Parkinson's disease, and they do include some on bowel and bladder issues.
Okay, thank you, Heather. And I have just one slide to share before we move forward. And in truth, it's a fairly crudely prepared graphic, but it'll help me illustrate a point. As I mentioned to everyone, my focus from a Parkinson education perspective has always been about the role that medication plays in the management of Parkinson's disease, and specifically the importance of timely and efficient dosing and usage, if you will, of medication. I know that Melissa is going to speak about this as we move forward, so I won't spend a lot of time on it, but one of the big concerns from a efficacy and efficiency perspective of medication with Parkinson's has to do with making sure that it's absorbed appropriately in the bloodstream. The challenge with constipation, of course, is that when a person becomes constipated, there are greater difficulties in absorbing medication. And because that is a muscle motility issue, when there are challenges in absorbing that medication, it means that you see more issues with movement, mobility in general, but also some of the internal processes, including those that can cause constipation. So what you see is, again, an extra challenge, if you will, with constipation, which means extra challenges in absorbing the medication, which really can start a challenging cycle for people, leading to bowel obstruction, which can cause more significant issues, and also leading to other motor and non-motor complications through failure to absorb the medication. I couldn't find a photo to share with you, but I've actually had it shared with me from other staff here that they've seen x-rays where you can fairly clearly see what appears to be residue or unused medication sitting on top of stool in the bowel. And again, it can become a pretty complex issue for people. So it's something that we're mindful of from a get it on time, from a medication timing perspective, and that's why we're choosing to share it with you here today, and that's why I'm happy that we do have Melissa with us. At this point, I will turn it over to her. So again, we're thankful to have Melissa Northwood, who is a clinical nurse specialist with the Continence Care Clinic at St. Joseph's Healthcare in Hamilton, and she's going to share some of her expertise on continence in general and how it relates to Parkinson's, including some of those clinical guidelines that Heather just referenced for us. So again, I thank you for attending, and Melissa, I turn it to you.
Thank you. Hi, everyone. I put a a kind of silly photo of myself up there because this is the first time I've ever done a presentation using this medium. So I thought you should be able to see me, and I wish I could see you all too. Just a bit about myself. I'm a registered nurse, as John said, and I work right now in an outpatient practice where clients come to see me when they're having problems with either urinary or fecal incontinence or problems, symptoms with their bladder and bowel. I do see some clients that will come to our outpatient setting from long-term care, and I would say somewhere between 5 and 10% of the clients I work with have Parkinson's disease. So here are my goals for today. We're going to start by talking about contributing factors to constipation, and then we'll move into contributing factors to urinary incontinence and learn some practical strategies that you'll be able to implement right away. I see we have mostly healthcare people from long-term care and also a few people online that either have Parkinson's or are a care partner for someone with Parkinson's. So you will find some practical strategies you can implement as well. I've put a yellow star throughout my slides, you'll see as we go along, just to highlight some particular concerns for people with Parkinson's disease that kind of go above and beyond some of what I would consider more general recommendations. And as John mentioned, we do have that question and comment box. So I'd encourage you to use that to pose questions as they come to you. John said that he would keep an eye on those comments and either interrupt me as we're going along, or we'll discuss all the questions at the end, just depending on the nature of the questions. So let's start talking about the bowels, and in particular constipation. This is a very common symptom of Parkinson's disease, one of the non-motor symptoms. And interestingly, I didn't know this prior to preparing for this presentation, that the symptoms of constipation can predate the other motor symptoms years before people are diagnosed with Parkinson's. The basic mechanism is that the Parkinson's disease causes the bowel movement or the stool to move slowly through the colon. That's the primary mechanism of what causes people with Parkinson's disease to have constipation. And you'll see I referenced my source there. As we go along, I've kind of put in where I've pulled the information from. The other part about this that Heather alluded to is that when you're having problems with bowels, it's a problem in and of itself, but it can also cause problems with the bladder, either symptoms or problems with bladder control. And that's just because there's really only so much room there in our pelvic abdominal area. So when the bowel is full and distended, it creates a lot of gas and pressure, and that in turn can put pressure on the bladder. And for some of the clients I see, that pressure can be so strong that it triggers a bladder contraction without the brain okaying that. So that's when people can be incontinent or lose control of their bladder related to the constipation. I was laughing to myself when John said he thought his picture was rather crude, because mine's even worse. I thought his graphic looked great. But here is what constipation looks like. So this, if you can imagine, you're looking in on pretty much someone's rectum as if you were facing them, as if the front had been cut off there. So we've got that, that direct view in. This definition of constipation comes from the Rome criteria. I don't know if you've ever heard of that. It's more of a medical jargon or something that physicians would use to categorize if someone has constipation or not. But basically, it's the formal definition is any two of these symptoms that are listed here. So if you strain to pass a bowel movement, if the bowel movement itself is hard, if the person is left with that feeling that they didn't completely empty their bowels, that there's still something left behind, or just a feeling of blockage in that anal rectal area. This point about the frequency of the bowel movements is really relative to everybody has a different pattern. But if your bowels are moving less than 3 times a week, that's pretty typical of constipation. Having said that, if you are a person that your bowels always moved once a day, I would say not moving once a day would then be constipation. So there's a bit of a personal definition in it as well. And the final point there are manual maneuvers to empty the bowels. And for those of you working in healthcare, you may have heard descriptions from people of the lengths they go to empty their bowels, either using a finger to remove the bowel movement from the rectum. Sometimes women put pressure inside through the vagina to try to get the stool that's stuck in the rectum. So those would be manual maneuvers. It's kind of hard to see in this picture here, but the one side is supposed to be normal, so the bowel movement is nicely coming down there through the rectum, coming down towards the anus to pass nicely to the outside, where on the right-hand side is the picture of constipation, where you've got this hard stool that's really distended the rectum. You can see how much wider the rectum is. Then you can see soft stool and watery stool backed up above that hard stool, and then more stool up higher, backing further up into the colon. So that is what the picture of constipation would look like. And if you've ever been constipated, you know what a rotten feeling that is. If you haven't, particularly when people are getting stool trapped in that lower rectum, it just makes them feel icky, for lack of a better word. You just don't feel well because there's that constant sensation and stretching of the rectum, which makes people feel quite uncomfortable. So just another great visual here is the Bristol stool chart. I don't know if you've seen this or if you use it in your practice. I know a lot of areas that I visit consultation-wise use the Bristol stool chart on their patient flow records so that everybody's talking the same language about what type of a bowel movement the person has had. So I've got that blue arrow pointing towards type 1 stool. These are the really hard pellets, small lumps of stool that are difficult to pass. And as well as type 2, that's also considered like a constipated stool. I've got the thumbs up icon by type 4 because that nice, soft, easy to pass, smooth bowel movement is what our goal is, because that is easy to move and easy for someone to completely evacuate in one go. And then you'll see the other bowel movement types are getting to be more liquidy. Another point is that we saw on that picture before is sometimes we can be tricked in healthcare thinking that someone's actually having problems with a loose bowel movement because they're having lots of watery stool or accidents with watery stool, when in fact it is just some liquid stool oozing around the really hard constipated stool that has blocked the person up. So I find this a really helpful tool in practice, particularly when I'm talking to my clients. I get out the picture and I say, show me what do your bowel movements mostly look like. So that might help you in your practice as well. Okay. In terms of kind of the way I see the world, I look at these issues with the bladder and bowel in terms of contributing factors. And every person that I meet that's having problems with their bladder or their bowel has more than one factor that's involved. So it's kind of doing that detective work to figure out what are the factors that are causing the problems for each individual person, and then tailoring a bunch of different treatments to address each of those contributing factors. I'm sure this is similar to the way you practice as well. So number one, most common contributing factor to constipation is low fluid intake. And Heather alluded to this earlier as well. And I'll likely mention this a number of times in my talk because it's such an important factor. So in terms of low fluid intake, what that does is it makes the stools really hard and dry like that type 1 on the chart. I should have my yellow star here. My graphics aren't working, but sometimes people with Parkinson's disease have trouble swallowing, and because it's difficult and uncomfortable, they might in turn limit or restrict their fluid intake. On another point, I've noticed that when people are having problems with their bladder, often the first thing they do is to start to cut back on fluid, thinking that that will help when in fact it makes things worse because it also negatively affects the bowels. Something that I learned about last month in this series, there was an excellent talk on the non-motor symptoms of Parkinson's and how common excessive sweating can be. And I thought, my goodness, that would even further dehydrate people with Parkinson's disease that may be having swallowing problems and may be limiting their fluid intake. So there's a lot of risk factors there for a low fluid intake. This I've pulled right out of the RNAO's best practice guideline on constipation that Heather mentioned at the beginning of the talk. So basically, the conservative strategy is try to increase fluid intake. So my first bullet says, drink 2 liters a day. Even small improvements related to what the person was drinking before will create improvements. Like small increase, in what they're drinking, they will notice improvements. I often meet people in my practice that are only drinking maybe 2 cups of coffee a day and a few sips of water to get their medications down. So if I can encourage them to try to finish 1 glass of water over the course of the day, then that is an improvement, and they might have some symptom improvement as a result of that. So although the ideal and what is linked to our best evidence is 1.5 to 2 liters a day, we don't always get there. Another thing is that I think just in the general public, people don't understand the importance of drinking enough clear fluids. So this is an important role you can have with your residents in encouraging them to drink clear fluids like water or juice. And then likewise, teaching them about the effects of caffeine, because that can further dehydrate them and make the bowel movements even more hard. So caffeinated drinks are things like tea or coffee, any of the pops like Coke or Pepsi that don't say that they're decaffeinated. I noticed that a lot of settings are changing to serve decaf tea or decaf coffee as the default, and then have residents request if they want caffeine. And I think that's a great way to go. Maybe not for breakfast, because I know a lot of people rely on that caffeine to get the day going, but particularly into the afternoon and evening. I bolded the word prompt here because this was another point that I learned from the seminar last month, that when people with Parkinson's, if they experience cognitive changes later in the disease, sometimes they need a reminder to drink fluids. And also, this has been shown, one of the only things that's been shown in research to really work well in long-term care in promoting continence is to prompt and remind residents to drink clear fluids. It has a really beneficial impact on their continence. The other piece related to Parkinson's disease is to have these swallowing concerns formally assessed and addressed. If that's why you learn from your resident that they're avoiding taking in clear fluids. The other thing I've learned in working in restorative care or rehabilitation is that other members of the team, if you have access to them, like an occupational therapist or a physiotherapist, have great ideas about how to make it easier for people to drink their fluids, like modifying the wheelchair to have an easy-to-access cup holder, for example, or even fixing a portable drinking container with a straw so it's easier for someone to sip on clear fluids over the day. So I would encourage you to call on your team for some bright ideas there. The next intervention or strategy I would suggest for managing constipation, this is after you've got the fluid intake up, is looking at dietary fiber. This recommendation I pulled from the best practice guidelines again, that residents of long-term care it's recommended that they eat 20 grams of fiber in a day. And it's not surprising that residents of long-term care, like ourselves, really come nowhere near to getting the recommended amount of fiber in our day. We're getting in only 20 to 50% of what we should for healthy bowel movements. Because it is so tricky to think of great ways to increase the fiber in your diet, this is a good role for a dietitian. If you have access to that in your facility, or if you can access that in the community, either through your family practice, or there is a great program through the Ministry of Health where you can dial a 1-800 number. It's the Eat Right program, and get advice over the phone from a dietitian. So in terms of looking at increasing your dietary fiber, food-based fiber is always better versus like a fiber capsule or some sort of fiber supplement. In the RNAO's guideline, there is a great list of food high in fiber in the appendices of the guideline, and you can view all that online. It's a great place to start to get some ideas. When I was looking at the Canadian and the American clinical practice guidelines on Parkinson's disease, they do say that you can add psyllium, so that would be, the commercial name would be like a Metamucil. But I just have, I agree with that in terms of promoting fiber. I just have a word of caution there for in a setting such as long-term care, where the person might not be getting that optimal clear fluid intake, and then you can run into problems where the Metamucil can actually contribute to a blocked bowel or fecal impaction. So I find the adding the Metamucil works well if you are able to walk and take in that 1.5 to 2 liters of clear fluid. That's just what I've found from experience. Another big contributing factor to constipation is lack of activity, particularly not walking. The bowel is stimulated by activity. It speeds up the passage of stool through the bowel so that the water isn't getting reabsorbed and making dry stool. And the bowel really seems to like the motion of walking, or where your knees are kind of lifting up towards your abdomen. So you can imagine if you're not able to move as well, or you're in a wheelchair, that the bowel's not getting that stimulation that it likes. So, of course, the treatment is to get more active. These recommendations I pulled again directly from the best practice guideline, and walking, as I said, is the #1 activity to help keep your bowels moving regularly. Any type of walking, you can see like the gold standard, walking an hour a day, 3 to 5 times a week. But even that recommendation of walking a shorter distance a couple times a day can be great to keep the bowel stimulated. I've got my yellow star here to remind me that, of course, how challenging is this to do when you're feeling exhausted, which can certainly be a consequence of Parkinson's disease. So it's even harder to get that activity in. Amazingly, there have been quite successful studies done of modifying exercise for people that do spend the majority of their time either in bed or in a chair, and kind of simulating that walking either by cueing the resident through pelvic tilts or rolling over, leg lifts, kind of bringing the knee in towards the chest. That can stimulate the bowel, as well as like a chair exercise. So that is spelled out in the guideline, but it's just something to think about even in your daily personal care with your residents. Is there, a lot of this you end up doing in the course of bathing or dressing, and if you added in a few extra kind of repetitions, that might help that individual get that activity that can help keep the bowels moving. I should probably have this one further up the slide deck in terms of its importance, because it is a big contributing factor to constipation when people don't have a set routine. And lots of people are guilty of this, of rushing off to work in the morning without breakfast and not taking the time that the bowel needs to move. The bowel likes to move at the same time every day. And usually, breakfast is the triggering meal. It stimulates that reflex that gets the bowel moving and wanting to empty, particularly if you have the empty stomach and then you're having your breakfast. So there's something to be said for people that don't have a routine. It's not the bowel's preferred way of operating, and it's easy to run into constipation then. The classic example of this is when you go traveling. Often that throws off your routine and people become constipated. The other part of establishing a routine is that it's easier for the bowel to empty when you're seated comfortably and in a squat position, which I'm going to show you a picture here on the next slide of that. So these are some instructions that you can share with your residents and your team, and also think about yourself in terms of having a comfortable position. On the right-hand side there, you can see the correct position for opening your bowels. This image is taken from a British publication, and I think that's the language that they use there. Anyhow, you can see that the person's knees are slightly higher than their hips. And that is what I mean when I say the squat position. The other important thing about this picture to note is that the person has a footstool there under their feet to raise their knees into that slightly higher than the hips. So a lot of things that we do in clinical practice are actually get people into a position that's opposite of the squat with our raised toilet seats. Some of the commodes can mean that the person's up higher and then their knees are lower than their hips, and it just is harder for the bowel to empty. So this can be a real challenge in real life to get into this comfortable position. Also, for people living in the community, I've had a lot of clients go to update their bathrooms, and they get the bigger king toilets, and then they run into problems with constipation. So they've had to get a footstool in there to compensate for that. So establishing a regular routine is really important. I realize this is a huge challenge in an institution, so it's trying to figure out when people's bowels moved before they came and what you can do to support people to go at a regular time. The other thing I notice a lot in my own practice is that what people's routine before wasn't adequate. I find a lot of people have struggled with constipation throughout their whole life. That doesn't mean that we can't help them now, but it's almost establishing this new baseline for them. And here is just to repeat or to emphasize what John said at the beginning of the presentation, that those critical medications for Parkinson's disease are not going to work if they're stuck in a portion of the bowel where they're not getting absorbed. So that's another important part of this. I just wanted to say a quick word about hemorrhoids, because they can certainly contribute to constipation, because it hurts to pass the bowel movement when you have a hemorrhoid. And they often develop because you're straining to have a bowel movement because the stool is hard. So it creates this vicious cycle of hard bowel movement, straining, aggravating of the hemorrhoids, and then incomplete evacuation of your bowels. So if you've had them, you know it's just dreadful. So really, the best thing to do is the strategies we've been talking about already to get the bowel movements nice and soft, but also to manage the pain of hemorrhoids so people can empty their bowels easily. And often this requires a topical cream, which a physician can order, or for clients in the community can buy over the counter, like an anusol that can be applied to the hemorrhoid to numb the pain as well as shrink them to kind of put a stop to that vicious cycle. As Heather mentioned at the beginning, medications are certainly a contributing factor to constipation. And, get out your magnifying glass for this slide, but I pulled this right from the guideline, again, the RNAO guideline, so you can review this if you're wondering if something you're taking or your residents are taking that's contributing to their constipation. I just wanted to make the point that how many of the people we know with Parkinson's disease have other chronic diseases that are treated with medications, the list here, that in turn can contribute to their constipation. And polypharmacy in itself is a risk factor for constipation. So the more medications you take, the higher your chances are of becoming constipated. In fact, you only need to be taking 4 or more medications to increase your risk of constipation. So having said that, I think the pharmacist is another really valuable member of our team, either the one that provides the medications for your long-term care facility or the community pharmacist, because you can now make appointments with your community pharmacist called MedCheck, and they can critically review everything you're taking, the interactions, and offer some advice to you and your physician about a better plan, or even identify medications that might not have as much of a tendency to cause constipation. So I think that is really worth doing. Along the same lines, this is something that I've been learning more and more about in my practice, and that is that sometimes we have to treat constipation with medications. This pharmacological approach that I have up here was developed. Pardon me, I'm going to have a sip of water. Oh my goodness, I'm too chatty. This was developed by Mary Nelson, who's a pharmacist I work with here in Hamilton. And here at the bottom of this pyramid is what we've been talking about so far. You're getting your fiber, you're drinking your fluid, and you're exercising. If these things aren't working, then we have to move up the pyramid and look at some medication support. So here, if you look at the second bullet, this refers to the second level in that pyramid, which is to add in an osmotic laxative. This category of medication is safe for long-term use, which is something that we didn't always fully understand, and we worried that it may in turn contribute to problems with constipation. But medications like lactulose or the PEG flakes are safe and effective to soften the bowel movement and help it move along. If you've got all the fluid, fiber, exercise, the osmotic laxative on board, and you're still having problems with constipation, that's when we would add in the stimulant laxative to help stimulate the bowel to move that soft stool along. This would be something like Senecot Senna. I did want to make a point here that Docosette sodium, or cholase, is not effective for chronic constipation in older adults. And this has been well proven in the research literature, but seems to be one of those things that just hasn't trickled down to practice. So I put the reference there if you want to show that to your prescribing colleagues. So at this point, I'm going to switch gears and talk about urinary incontinence. I don't see that any questions have come up so far, so I think if that's okay, I'll go over the few points about the bladder, and then we can take the questions at the end. So again, just like constipation, urinary incontinence is a common non-motor symptom for people with Parkinson's disease. Either having urgency, rushing to the bathroom, frequency, having to go frequently to pass their urine, or nocturia, which is getting up multiple times at night, or incontinence. But what I found really, I guess, upsetting in a way is that in looking at both the Canadian and American guidelines, they cited insufficient research evidence to know how to proceed to help people with Parkinson's disease with their urinary problems. It's just not an area that's been properly studied. But having said that, there are a lot of strategies that we can implement, conservative strategies to improve matters. I'm going to skip this slide here and come back to it somehow. And again, talk about contributing factors. So here I am, the broken record. Major contributing factor to urinary incontinence as well as constipation is low fluid intake. I think I mentioned this before, that the less you drink, the more concentrated the urine becomes, and then you end up going just as often, but for smaller amounts of urine, and that the concentrated urine that's not dilute with clear fluids is very hard for the bladder to hang on to, and it can stimulate an involuntary bladder contraction where the bladder squeezes without your brain giving it the go-ahead. So here I'm back to my same advice from the beginning of the constipation slides to prompt and encourage your residents to sip on clear fluids throughout the day. Again, here we are, caffeine. Caffeine tends to be more of a bladder irritant than it is a bowel irritant. But it is probably the second to encouraging people to increase their clear fluid intake is working with my clients to decrease their caffeine intake when they're having problems with the bladder. So it's good to think about what you serve as the default at your facility or in your home. So here you offering decaf beverages, and if people are having problems with urinary incontinence, to limit the coffee or tea or caffeine to 1 to 2 cups per day. If making a lot of urine at nighttime is a problem, then really looking at the timing of the caffeine as well and avoiding any caffeine after midday. A urinary tract infection or bladder infection is the most common reversible cause of urinary incontinence. And basically, the infection irritates the lining of the bladder and causes the bladder to contract, again, without the brain saying it's okay. This can be tricky to detect, particularly in older adults, because they don't always get that classic presentation that's listed here of pain or burning on urination, or even that the lower abdominal pain or tenderness. But certainly, those of you that work closely with residents will know. You can tell by the color and the odor of the urine and the quality of if it's cloudy or has sediment in it. Sometimes people have gross hematuria where you can actually see blood in the urine, but more often than not, the blood is microscopic, so you can't see it with your eye. What I notice more in long-term care is that people aren't themselves. Either their thinking has changed, or their strength in walking, or their incontinence has gotten much, much worse. If you notice that in one of your residents, start thinking about that it might be a urinary tract infection. And these are some of the risk factors for people to develop them. If they've had one before, the postmenopausal vaginal atrophy pretty much applies to all women after we've gone through the menopause. The tissues of the lining of the bladder and the vagina become much more fragile and dry, and they're more susceptible to infection. If you or your residents have diabetes, women with diabetes are 2 or 3 times more likely to have problems with bladder infections. Inadequate personal care wouldn't really apply to your residents, of course, but in the community I see this quite a bit, where people are limited in their mobility and their ability to clean and wash if they are having incontinence. Again, constipation is a huge risk factor to create urinary tract infections, particularly in women. So you'll see none of these factors actually in that list are related to Parkinson's disease. So this is something that your resident with Parkinson's disease can be at risk for over and above the Parkinson's disease itself. But the important point I learned from Sandy's presentation last month is that nothing happens fast in Parkinson's disease, which I think is a very sage observation. So if you notice that your resident's having sudden change in hallucinations or delusions or cognitive changes, to question if something's going on, like an infection in the bladder, because it's definitely a sign, if it's a sudden change, that something else is going on. Here are some strategies to prevent bladder infections. Drink more, again, I can't say it enough times. Prevent constipation. For people that have recurrent bladder infections, we often recommend drinking cranberry juice or taking cranberry tablets. It's very effective in preventing but not treating bladder infections. For your independent residents, I notice a lot of older adults have a hard time, this is women, wiping after they've urinated from the front to the back or after a bowel movement. So they're drawing the bacteria from the bowel up into the bladder. So if you can provide support in that way and teach your independent residents to make sure they're wiping from the women from front to back. For your residents in your settings, I don't think the perfume soaps, powders, bubble baths are an issue like they are for some of the clients I see living in the community that are worried about odor and are trying to mask the odor from the incontinence with these products that can be very irritating. Just a note on this. Later in the disease with Parkinson's, people can have cognitive changes. This can affect their continence by reducing that sensation that their bladder is filling, or even changing their ability to sequence getting to the bathroom in time. Additionally, changes that happen with their vision, with double vision or even visual spatial relations can make getting to the bathroom safely very challenging. So to keep your eye out for that. And really the best way to manage that is prompted voiding. This, unfortunately, is a talk all on its own and a whole lengthy guideline, but it's a strategic way of ensuring that you're providing the right support at the right time to the resident to get to the washroom to empty their bladder. So I would direct you to that great guideline on prompted voiding. So just to sum up, these are basically my takeaway messages. Anything you can do to encourage your residents to get increase their clear fluid intake will help their bladder and bowel. I can't say that enough, and I think I may have said that enough in this talk. So providing support and cueing and reminders can help with both the bladder and the bowel. Often we are looking at, particularly in people with Parkinson's disease, treating the constipation with medication. And facilitating exercise in any form is great for the bowels, but it also helps promote continence as well. On the next few slides are the sources I used to prepare for this presentation. I just wanted to draw your attention to the third one here, Cowie et al. This is a great little handbook that we are making out of, or that we've produced, oh my goodness, I'm sorry team. We've just recently updated it, and it is almost ready to be sold, and you can order it through McMaster. And it is written for caregivers of all backgrounds with some great tips. Then I wanted to, I think Heather had told you about the guidelines. They are available online, and we just recently went through a big, oh my gosh, it's not that recent. It was 2011. Time flies. But we updated those guidelines. I have my contact information here. If you had any questions, please feel free to be in touch with me after the presentation, and I'd be happy to talk to you more. I don't know if anyone has any questions. Well,
I'll interject and say thank you, Heather, and I think we'll see a few coming in the chat box here, but should note that a quiet room means you're just covering everything very thoroughly, right?
Thanks, John.
I know that from my end, I certainly enjoyed the presentation. More than anything, also just your energy. I found it easy to follow along. Pardon me. So thank you for that. Again, from a Parkinson perspective, I see great value in just pointing out, as you went along, some of the complexities that people experience beyond just being constipated or beyond issues with urinary urgency, frequency, things like that. I know you noted nocturia, for example, and from a Parkinson perspective, we think of that, or generally people tend to think of that, pardon me, as just a complication, as the urinary urgency at nighttime. From a Parkinson perspective, and keeping residents healthy and well in long-term care or in other settings, of course, we want to think about how that presents other complications where issues with balance and falls come into play and things of that nature. So I thought the presentation for me did a nice job of weaving things in, and I thank you for that.
Oh, thank you. I guess my bottom line is that it's complicated, and there's usually multiple contributing factors that we have to work away at. I see that there is a question there from Tina about that, my reference about Docusette sodium.
Yeah.
That, it's in my slide deck. It's from the, have you heard of the Beers criteria for, they're called potentially inappropriate prescribing for older adults. And it's quite a list of medications that are on that tend to have more harm than good. But the Docusette sodium made that list just because it doesn't do anything, really. I mean, it's effective in, for the young woman after a baby to make sure her first bowel movement is soft, but that's about it. So where did I have that? It's after the pyramid, my pharmacological approach. So it's the American Geriatric Society, and I believe, oh, there it is, that one is available openly online. Yes, and I see Marlene's comment about lactulose. This, as a gerontological nurse, has taken me a long time to get my head around because we were always taught, avoid long-term laxative use, avoid long-term laxative use. Well, it's just, our understanding of that has changed in terms of long-term, what medications are safe to use in the long term, and the negative effects and the impact on your well-being and your quality of life of being chronically constipated would way outweigh any risk of taking a medication that simply draws water into the stool. So, the tough thing is that not everybody likes the lactulose because of its sweet taste, and some people say it makes them gassy or burpy. That's where the advent of those PEG flakes, like the Laxaday, Restore-Lax, have just been awesome because those are easier for people to tolerate.
Okay, well, I think then that wraps your questions, Melissa. Heather, I don't know if you have any further comments? You're quiet on us again, Heather. Okay, so perhaps others
hear her faintly, but
perhaps others are hearing us, or hearing you, but I know that I'm not on this end. I do want to take the time to thank Heather and the Registered Nurses Association for being involved in this project. They've allowed us to reach a really great, a broad group of people that we've not had the opportunity to speak to about Parkinson's before. So I do appreciate your participation in this project, specifically Heather, the RNAO, and to everyone who's joined us as well. We're happy to have archived all of these sessions as we've gone along as well, so keep an eye out for some hopefully strong materials that we can use moving forward to really help aid in the education of people about Parkinson's, particularly in a long-term care setting across a really broad spectrum. So I'm thankful for that. I'm thankful for everyone who is attending or who did attend today. I see Melissa with a response there, and provided no further questions, class dismissed, and again, thank you all for attending.
Oh, I see Heather's still typing. Oh,
She's going to try to communicate with us through what medium she can. There we go. Thank you, Heather.
Thank you.
Thanks, everyone.
Thank you.